Welcome everybody, it's lovely to see you here today. My name's Ruth Wallace, I'm the Dean of the College of Indigenous Futures, Education and the Arts at Charles Darwin University. It's an absolute honour to be here on Larrakia land, beautiful Larrakia land today, and I want to start by acknowledging the traditional owners of the land on which we meet and all of the lands that you are on today too. There are so many people who've come before us, so many people who work with us and who are going to be the future of this place. And they're the partners in everything that we do. And so I acknowledge all of those people and all Indigenous people participating. Today we are celebrating International Women's Day, a couple of days late, but that's okay. We needed to make it a date that everyone could attend. And it's just an absolute pleasure to be able to have such a wonderful person as Dr Wendy Page here to celebrate Women's Day, International Women's Day with us. So a shout out to all the women involved and all the men who've joined in to support women around the country and to hear about what fabulous women are doing. Just to let you know, we will be taking questions at the end of the presentation. So if you use the Q&A tab down the bottom of the screen and start logging your questions, we'll handle them at the end of the presentation. So it is a great joy to introduce Dr Wendy Page, who for more than 30 years has worked to improve Indigenous health in the communities of North East Arnhem Land. In 1993, Wendy joined the Miwatj Health Aboriginal Corporation in Nhulunbuy, where she is now the medical director. And you have the medal for sticking with and supporting people in the region and partnering in the region. I think it's just an amazing achievement. Wendy has worked to eliminate Strongyloides, and we're going to hear more about that and check my pronunciation as we go through. This chronic and potentially fatal disease is caused by a parasitic roundworm that's common in remote Aboriginal communities in Northern Australia. Her efforts have been instrumental in reducing the prevalence of Strongyloides in North East Arnhem Land from 60% to below 10%. That's an amazing achievement. She has also published widely on the Strongyloides worm and is a world-renowned expert on the disease. She's also passionate about mentoring young doctors, serving as a supervisor in Nhulunbuy, as an examiner in Darwin to help registrars qualify as GPs. So you've touched many, many lives over your career. So congratulations on being awarded the NT Australian of the Year, a huge achievement, and thank you very much for talking to us today.
Thank you, Ruth.
You've been dedicated to improving Aboriginal health outcomes for over 30 years. So where did that journey start? What inspired you and what made you want to be a GP?
So I probably go back to when I was a medical student in the 1970s, and I went to the Aboriginal Health Service in Brisbane, and Aboriginal nurse by the name of Pammy Mam said, you know, what do you want to do? Where do you want to work? And I said, oh, I wanted to work in developing countries. And she said, well, why do you want to work there? You know, we've got so much to be done within Australia. And I did work in Tonga for a couple of years as an Australian volunteer, and but really my passion has been in Aboriginal health for a very long time. And in '86 I joined the Aboriginal Health Service in Brisbane, and then on to Stradbroke Island, and then in '93 came up to Gove, and my husband, I said to my husband, well, we'll need at least 5 years, because that's the commitment I believe you need in Aboriginal health to get to know the community, for the community to know you, and that's really been home for that length of time. And even when I have left for periods of my parents' end of life, or you know, for other reasons, managed to keep coming back, and I love it. You know, it's just been an incredible privilege to live and work in North East Arnhem Land, to work for Maywatch. That region is Maywatch. North East Arnhem Land is the Maywatch region. And that's why I proudly wear the Maywatch logo as well.
So one of the things that you are well known for is you've not only done that work, but you have supervised and mentored so many others in the region and worked in partnership. Why is this so important for the communities and for the territory as a whole?
I think it's important for people to realise just how special it is to be working in Aboriginal health. I'm not an expert in Aboriginal health. I don't know anyone can be, but that's just a title that was inadvertently added. but my expertise is in strongyloides. In terms of supervising, that's part of the role we have as we get older. It's a traditional way of learning, and you'll also have that way of learning. It's a vertical way whereby those who have the experience over time get to share with the next generation, so that next generation coming through are learning from the people who have been before them. And so I think I say to medical students, the patients are your teachers. Listen to the patients. The patients know their body, know their story, so it's listening to them first. And then you can bring out the textbooks and think, oh, what's this? What's this? That's probably been part of the strongyloides one. What is this strongyloides? So, you know, you then go in deeper because you're looking after that particular person.
So could you tell us a little bit about Maywatch and the work that they do, but also the way that you have learnt from others and work in partnership around with amazing people?
So when I first went to Maywatch, it was after having worked in southeast Queensland. Miwatj Health Aboriginal Corporation is an Aboriginal community-controlled health organisation known as ARCHO. So they're not government run, they're run by communities where there's an Aboriginal community board where the locals say these are the people we want on that board. Within that ARCHO title, Aboriginal Community Controlled Health Organisation, community control is at the centre. And what's really important is that we listen to Aboriginal people and what their needs are. We can think, this is what we think will work, but is that what will work for them? I have this one where I say, this is the hospital model, it's a hierarchy like that, and that's often the government model, it's a hierarchy, whereas in Aboriginal health, I do the reverse and say, we are listening to the people. And what are the needs? What are their priorities? What do they want to have addressed? And follow through with what their priorities are.
So tell us about some of the people that inspired you on that journey, some people that you met out there who helped you develop your practice.
So when I went there in '93, it was very much a working together model. I had an Aboriginal health worker beside me, and they would guide me what was culturally appropriate, not appropriate. It was just absolutely fantastic working together relationship. In 1995, we had a parasitology course at JCU, had come to go bring in the microscopes. So seeing is believing, and that was, you know, where's your evidence that something exists? Well, the microscopes were a way to show that. And I learned about Strongyloides stercoralis and why it was different to the other ones, such as hookworm, etc. And then it was the following year when we set up our clinic at, which we call Manga Clinic at Gunyangara Clinic, now Gunyangara Clinic. And someone came in and I thought, oh, you know, I recognised that the symptoms behind why they were septicemic and why a 25-year-old might be passing away at an early age could be due to strongyloides. So that person's still going to work and recovered from their 2 episodes of septicemia. And then along the way, I started to recognise that we had a lot of strongyloides. So it became that looking into books. We did books then, we didn't have the Google, didn't have, that was 1990s. And then in 1999, senior Aboriginal health worker, traditional owner, you know, just this amazing woman, strong woman and colleague passed away from disseminated strongyloidiasis in Adelaide. And that was just a huge loss to us, to the community. So it, you know, it had a huge impact on those around. And then it was the following year when I was describing it to her sister, or later in that some months later, and her sister was still grieving. Her sister was Dr Wendy Page, so saying how high, you know, the hierarchy was with people being affected. I shared the story with her, and we'd started to introduce ivermectin from 2000, And she said to me, "Let not her death be in vain." So we've taken that forward. In 2001, we held the first national workshop in Gove Hospital, and there was a day before where Rick Spear and colleagues came over, and there was a microscopy session for Aboriginal health workers who were able to look down the microscope and say exactly what was under there. And at that workshop, another woman who has since passed as well, another leader, said, "We've had this strongyloides for so long, why hasn't something been done?" At a women's conference held at what's now the Garma site, but was Gulkula at that point in time, there was a women's conference, and they came up with two recommendations. One was that they requested education, and they requested screening. So that was a recommendation from the women at the women's conference, but it was for everyone. And so we started to implement a program there. That hit with some resistance from elsewhere, and we did make quite a bit of progress. And then there was a time where we were writing up our findings that ivermectin was better than albendazole, and it was okay to treat individuals, but for some reason or other, it wasn't okay to treat people who are endemic communities. And that was very frustrating, because I don't know of any other disease that people can have that you don't treat because they're living in an endemic community. You need to actually treat the people who are in the endemic community. And I can remember a time, parents were towards the end of their life, thinking, this is so hard, taking on health authorities and the perceived barriers. And I can remember thinking it would be easy. I could take on this very nice lifestyle in a first world country and almost be walking away from it. But as the GP for that community, with the commitment and what had been put on my shoulders to do, I've stayed with that. I've had continued encouragement, inspiration from the women who have walked alongside me, some of whom aren't here now, which is a reality of the lower life expectancy, and that's a real tragedy. But we know with strongyloides we can prevent deaths from that. We can prevent the clinical complications. So it's one thing that I'm able to take further forward. On an international scene, it's the most neglected of neglected tropical disease. And so we've learnt a lot within Maywatch and being able to take it forward, because the people in the Yolngu have said, we don't want this disease that's not common anywhere else. Why should we have it? So we've got strategies, and we want to be able to share those strategies. We believe that having a national strongyloides control program would make that difference. We have a national strongyloides working group that came out of that first national workshop in Gove 20 years ago. And there's now a group called Strongyloides Australia Incorporated, which is a non-profit organisation where it's a multidisciplinary group with the same goal, that we want to actually eliminate this neglected tropical disease from our communities.
So when you talk about strongyloides, I think you're going to have to tell us a little bit about it. Sorry if you're eating your lunch. And I think there's an image that could help with that. Would that be helpful to bring that up?
Yes.
So if you could share that image, please, Katrina, and you'll be able to take us through and give us a bit of understanding.
Okay. So when we look at that image that's there, it's that's the strongyloides life cycle. It's actually an updated life cycle from the one that was there in 1993. So what makes strongyloides very different is what you see on that right-hand side. Now, if you want to refer to this particular life cycle, you can go into look up the Tropical Health Orientation Manual. That's essentially the curriculum for anyone from down south coming to work in the territory in the health area. It contains a lot of the conditions that we have that people aren't aware of when they're from down south. So there's a page in there, a few pages in there. I'll just show you the actual book so you can see what it's like. So if you want to know more about coming to the, if you're coming to the NT or in the NT and want to have some more detailed information, that's within there. Strongyloides is within there as well. The reason, so this is how most people learn about Strongyloides, and it's a helminth microscopic worm. It's only a female in the gut. The female doesn't actually need a male to produce more larvae and to have a cycle that goes on in the body for decades. So people can be infected as a child, years later, decades later, have a complication. They're given corticosteroids, and that's when the female in the body starts producing a lot more, recognises the host is not particularly healthy, and it's time to get out. So they go into multiplying into its millions. So disseminated strongyloidiasis is when it's multiplied into its millions. But if you don't look for it, you won't find it. It's just microscopic. And often it's found in the sputum in patient in ICU. That's too late. We want to be able to do something about that earlier, picking it up earlier, and that's why we've included it within our adult health assessment, so we can identify people early, treat them, follow them up to make sure they've eradicated it. But the other part to this, and the reason that's up there, is that there's the outside circle, which is in red. I've always concentrated on the clinical symptoms and the humans, but the outside cycle shows the baby, it comes out as a worm. It doesn't come out as an egg. It comes out as a baby worm. And then it becomes a falariform, which is a teenage worm, and that wants to get back into the host. So it's looking for a host. And then there's a male, female that come out as an indirect cycle. And because that female still, it increases the number of worms in the environment, but that female only produces one generation because those falariform larvae, again, wanting to find that host. It only lives for a short time in the environment, probably only up to maybe 3 weeks if it's the right environment. So that concept of why bother to treat if they're only going to get it again is not because there's a high amount in the environment. It's only there for a limited time, and it's only there when there's been some fecal contamination in that particular area. So the reason it's also there is I identified in the previous life cycle, they thought because there's a male-female, it must go on indefinitely. It doesn't. There's not an indefinite environmental life cycle. So in 2014, I identified 3 areas that needed to improve the CDC life cycle. And in April 2015, they upgraded that life cycle. So that is a life cycle that tells more about how the Strongyloides work. And inside the body, there was a concept that it had this lovely ordered route, but we know from parasitologists who did work on dogs, labelling the E. coli to the parasite, they know that it's not this ordered pathway of going into the blood, right side of the heart, and we wait, and we'll get off the bus and then we go into the gut, and it's actually random migration. So we've learnt a lot more. So this updated life cycle, that's where a lot of people learn about Strongyloides. So it's important that people actually look at the latest updated life cycle.
So how can you use this wonderful award that recognises the breadth and depth of your work what's the messages you would like to tell others, and how are you going to use this recognition?
So the first one is people saying Strongyloides, and Ruth has it down to a T. Strongyloidiasis, strongyloid, it relates to the worm. The iasis relates to the disease. Strongylloides stercoralis is the particular species that is just so different, that likes to live in us and can live for us. It's got a very nice home inside us. It doesn't mean to kill us or to make us sick when it takes the bacteria from the bowel elsewhere to the body. I don't think that's its intention. It's just that's the way it travels. And it's the disseminated phase is one phase, but it's also the other morbidity that comes with it. The disseminated strongyloidiasis is a mortality that's killing people. It's the morbidity where people can have intermittent symptoms and not know that's what it is. And yet when they're treated, they can be treated now with ivermectin, very effective treatment. Get followed up to see they've got rid of it, because it might be hard to get rid of in some people. So we've got an effective form of treatment. What we want, the goal with this award, is to raise awareness of this neglected tropical disease. We know we've got a really good public health system in Australia. We're aware of that because of what's happening with COVID and raising awareness on what's a hotspot, endemic hotspot. We know that translates to strongyloides. How you do it, what you can test with, how you can treat. There's no vaccine for strongyloides. So we know we've got a really good public health system. We want to use that public health system to make it notifiable. So we identify where those hotspots are, and then you can go in with a good system. Identify those that are positive, treat them, identify what the factors are around that need to be addressed. And that might mean that the sewage system needs to be addressed, as one environmental health officer in Barkly region. One of our team did a fantastic job and actually, brought about improved, got about $1.2 million to upgrade the sewage system and the maintenance that goes with it. And they're the sort of interventions that knowing about strongyloides is both addressing a disease we shouldn't have, but when we find it, we need to be doing something about it. So if you've got a 5-year-old that's come in with strongyloides evacuated from a community, there should be a response that says we can do something in that community, identify who else has it, because it's treatable. It's now treatable and it's preventable. So our goal is to make it nationally notifiable and to have a national strongyloides control program. We can do it.
And there's progress already in that direction.
Well, our group is doing it, but I see this is the opportunity to remove the neglect in Australia from the most neglected tropical disease. It's 370 million people worldwide. So what we've been learning in Arnhem Land and what we're learning in Australia is we can do more.
Yeah.
So we can take a lead role in what works as well.
Great. So I think we might have some questions already coming through, and I might open some of those questions up, because now you've started that conversation, everyone now is going to need to be an ambassador and a supporter, and so they're going to need to know what to do.
We have one question in from someone who was actually diagnosed with strongyloides.
Yep.
And obviously I'm not going to name that person, but they wanted to know how big the worms were.
So it's microscopic. You can't see the worm. There are other helminths that we have that you might be able to see, like pinworm, threadworm. There are other ones we might be able to see, but it's actually 2 millimetres. So it's much smaller than hookworm as well. So that's why it needs microscopy to be able to see it. But because it's an intermittent amount in the faeces, it might not be seen at that particular time, where, you have to have multiple. It's the larvae that exist in the faeces. So often the diagnosis depends what phase. There are different phases, and that's described in the Tropical Health Orientation Manual. It'll be described in there. It's also, there's a paper that we put out for GPs, but it's also very useful for patients as well, or for anyone who's interested, and it's called Chronic-strongyloidiasis, Don't Look and You Won't Find. So that gives guidance on the symptoms people might have, because it's not overt symptoms, and it might be that someone else has something else even though they might have gut symptoms or respiratory symptoms or rashes. But if you include it in the differential diagnosis, which means you just think about it, could it be strongyloides? A blood test in someone whose immune system is intact is a good way of checking. And if you do have it, it's usually a case of just getting, we work on 2 doses of ivermectin, but it's that follow-up 6 months later to see that they've become negative. But it's a case of going to the GP. If you need to take that article with you, take the article with you. If that GP needs to phone up me, I'm more than happy to go through it with them because they will know the person. I've managed patients from a distance based on, this is what we can do, and giving, some feedback to the GP. One of those, in fact, was an ex-POW who also had strongyloides, had it for many years, and it was shared with another ex-POW who had carried the disease for 60 years and had become well and said they'd felt better up than they'd felt in the last 60 years because they just live with intermittent symptoms. So it's something that if people do have it, you can make that difference. And the person that I dealt with the GP, I conversed with the GP, this person sent me this beautiful bunch of flowers and told me the story of how, as an ex-POW, he'd come back, but he was also looking after a disabled wife, and he had to plan when he'd go out to do the shopping because he'd need to plan where the nearest toilet was. Now, this is people that, had suffered for so many years, and then having ivermectin, something as simple as that, recognising that this neglected tropical disease, something could be done about it, and then getting their lifestyle back.
How widespread is the disease in Australia?
We don't know.
Okay.
We don't know. Refugees are screened with a health assessment. The other people, we know we've got hotspots that we can be tackling, and that's my emphasis within Australia, working in the endemic communities. But people that have travelled overseas, if they come back, there was a study out of Victoria. There are 42 geosentinel sites around the world that look at returned international travellers with infectious gastrointestinal disease. So they're looking at the faeces, people coming in, they're feeling unwell, and there's a certain site in Victoria that does that testing. Strongyloides came in as the 5th most common pathogen in returned international travellers with gastrointestinal disease. So it's not something that's only in Indigenous communities. It's something that is, when we're estimating 370 million worldwide. So that's why for GPs, they wouldn't do a standard screening for it, but they would probably, if someone's unwell, they'd think, could this be strongyloides? Let's just do a check. And they need to go follow up until they're actually negative. So it's raising awareness amongst the health professionals. What we found in the Maywatch region, we developed an educational tool, which was fantastic. It gave the story, the importance of knowing this little parasite, which is what Yolngu wanted to know. They wanted to know, what does it look like? What's its behaviour? What makes it special? And then on the back of the flip chart, we had the message, which was, the standard health message. What symptoms you can get. What test you can have, what treatment you can have, which are often the standard health messages we get. And we believe what the doctor's saying. Whereas what was important was Yolngu saying, we want to understand what this little microscopic worm is like. We want to know.
That's okay.
Sorry, Katrina, did you have another question?
Are you there?
Yes.
Oh, sorry. Sorry.
That's all right.
No, we don't have any more questions at this moment.
That's all right. That's good.
You want to continue?
So one of the things I was thinking about was they've been doing COVID fragment testing in waste in wastewater and being able to say this could potentially be a hotspot, this could be a problem. Is that something that there's potential for?
It's a very interesting question. And one of the people that came to our National Strongyloides working groups had done some testing and did identify it. And I think that was in Western Australia.
Oh, right.
So, but that connectivity around being able to identify where it's coming from, and we did have a thought that, you know, if we did something around the golf courses that are fed by sewage, you know, could there potentially be any strongyloides there? We might get some more input. But look, there's just so much we don't know, and for Australia to put some more research and ask some of those questions, we're not only doing it as a first world country, what we learn from that in a research capacity, the more we learn, the more we're able to share.
So you've had a strong partnership with women to build the story, to do the research, to understand how to tell that story effectively on country. What are the things that you've experienced around women's voices leading and the challenges of having women's voices leading in health that have made a difference in the Strongyloides story or others?
Well, I think I've mentioned some of the people who are there. Women have a strong role in health. They always have. And so I think that continues. That's my inspiration when I'm thinking this is tough, and I think about the challenges that younger women have had, or women, they're such strong women. I mean, look at Miriam Rose. You can see it. You can see it in her. So as a Senior Australian of the Year, you know, she's just up there. So when you interview her, you don't miss that. Don't miss that interview, because I won't miss it either. You know, and she represents that spiritual strength, saying, you know, we've learnt your ways, we've learnt your English language. You know, we want you to come and learn from us. And for me, that's also that message that I think Aboriginal women have to share as well, and I've learned from. You know, and that's why I feel absolutely so privileged to have lived and worked where I have, and just learnt so much. And that's why I say, you know, people who come, you know, our I say patients, but the people that we look after in our role in health, they have so much to teach us.
And have you seen a change over the time that you've been out in the region and also in the profession about women's roles and the voice that women have had and the way that that's changed the workforce?
I want to acknowledge the women, particularly the female doctors and female GPs, because in the early days it's been very hard to recruit the male doctors, but a lot have been the females who are out there in the health profession. And I think very early on, it was in the early 90s when GPs were going out there was much more female GPs out there than there was male GPs. It's to also honour all, because male and female, we work together, you know, and we acknowledge diversity. And there's not one better than the other, you know, it's a how we work together as a team. And that whole working together concept, that's what I learned from Yolngu, we're working together. And so that translates across, and the importance of relationship.
We need many voices to be able to move the work forward at any time.
Yeah.
And are there areas that you'd like to see more change in the health profession? What's the future hold, do you think?
I see, going forward, I see more Yolngu taking control of health, more Aboriginal people being in that workforce as well, and I think that's happened. In terms of females, I have to say I've been incredibly privileged. When I went through medical school, it was something like 50%. And I must say my mantra my favourite song at that point in time was Helen Reddy. People that go back to the 1970s, that was my one. Yes, we can do it.
Yeah,
we
definitely.
go forward. Yes.
I think I can see another question there, Katrina.
Yeah, we do. Someone's come in and said that it's been mentioned that Dr. Wendy has mentored lots of clinicians and I'm sure has benefited from mentoring herself. What do you think are the most important factors for a successful mentoring relationship?
I think the mentoring relationship is about, I'd say, care. With RACGP, their logo is in Latin, but that translates to caring with knowledge. And so in the mentoring process, it's how do we look after the people that we're mentoring? And I think that care is huge. The next generation coming through they have lots of knowledge, they have lots of information, and they need to be cared for. That mentoring for me is because as they have a lot of new knowledge, so it's always a two-way process. It's not a one-way process. But I think it's that, how do we support the next generation coming through? We want them looking after us, so we want them to be as good as they can. So it's where do they find the knowledge and finding that knowledge. But yeah, I'm not sure if that answers the question.
What made a difference for you in mentoring when you were mentoring?
I think it's having people that you say, yes, that's the model that I want to go down that pathway. And obviously that's happened along the way, feeling supported. I remember when I was in Tonga, it was a pretty isolated position, and I had an RACGP mentor for 2 years' work doing obstetrics and then anaesthetics. I got 6 months. But having someone who was just able to say, give a little bit of input in it and that was being in isolation, but having I think they were called training advisors at that point in time. So it was just that link. And if you needed to go to someone to ask a question, you could go to that person. They might not necessarily have the answer, but they would look to give that support and reassurance. And I think in the early years, it's very overwhelming. And it's that sharing the journey. There's a pathway. I mean, you're learning for life. When you start medicine, it's not, you know it all. You're learning for life. And to feel supported along that way, I think is a big part of that mentoring, because it's how people look after themselves. It's that they're caring for patients, but also how people then caring for themselves. And I get reminded when my shoulders go down and I feel a bit heavy laden, someone comes along and says, well, what about self-care, Wendy? So I think that mentoring that's probably how I see that support role and guiding people through sometimes what are very challenging and difficult times. And the other one is, for me, I've had to look at what's one of the guiding things, and I've shared it. It's in Bush Crisis Line, the manual that CARPA put out. They had a group, Bush Crisis Line, that I was on the steering group for that. And within that, as well as what was on my mother's dressing table, was the Serenity Prayer. And the Serenity Prayer is, Lord, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. And I think wisdom comes with time, but struggling in that area. And we take on a lot of things that you might say are vicarious trauma, where we're impacted by, what someone else is feeling. and working out, is that something you're able to do something about or something you're not? So that's that question that I use for myself, and that's a question that I will share with registrars. I'll share with people who work in medicine, because it is very challenging. So it's working out what that balance is. And the other one is that courage. You know, oh no, it's someone else's problem, it's whatever. If it's within our sphere, and that's for me, the courage is you know, when I thought, well, you know, when I was thinking this is so hard, how do I take this on? There's so many barriers, and was it within my sphere or not? And so Strongyloides has been within my sphere, and so it's having the courage to say yes. And that's where I say my inspiration when I'm thinking, in that courage, well, that inspiration has come from these strong, resilient, stronger women that have said, keep going, Dr. Wendy. You know? Yeah. And so mentor, it's hard. I mean, medicine is hard, and there's lots of expectations and general practice. Why go to general practice? And general practice means you're part of the community. I think specialists have to live in cities, so they're more removed, and I think the worldview can then sometimes be more removed, or it might be more hospital-based and people come in and they go out. But in general practice, you're part of that community, and that's where it's absolutely so special as a GP to be in that very privileged position to hear people's stories.
I hope that everyone will now go away and go and learn about Strongyloides. We'll be able to say it effectively, but also we'll start to champion the change that you have worked on for so long. I really commend you and Maywatch for the work that you've been able to do for such a long time. And congratulations again on the award. It was just such a wonderful achievement, and I think one of the best awards that we could have seen. Miriam Rose as well. And we're going to, of course, the only hard thing with the awards in the territory is there's just so many fabulous people.
Oh, absolutely, absolutely. And there's so many people I can think of that, you know, could have that award. So the other thing is, when you're thinking about nominations, if you know someone, think about them. Don't hesitate to nominate them. I mean, the last thing in the world I would have thought would have been to have received this award, but it's the opportunity to take the Strongyloides further forward. And if we encourage more GPs into Aboriginal health, absolutely fantastic.
Yep. So I think you completely show us what it means to choose to challenge, which is the theme here. So thank you very much for presenting today. And we are all behind you in the work that you're doing. So all the best for it in the future. Thank you very much for joining us today. We will continue this series as it should be International Women's Day every day, of course. So next week, on Wednesday, the 17th of March at 12:30, we have the Young Australian of the Year, Isabel Marshall, joining us from Adelaide to talk about her work to end period poverty in Australia, which is already having impact, I think. We encourage you to keep in touch with all the things that we're doing. Look at our website, become a friend of the Northern Institute, visit our social media sites, which are incredibly busy, and will keep you up to date with everything that's going on, and invite you to many more events like this. We also welcome you to have a look at the cdu.edu.au/northern-institute/IWD for International Women's Day 2021 to find out more about the activities we'll be doing. So have a great International Women's Day month, and take care, and thank you very much for being with us today.
Celebrate.